R2 and big R2 genotypes. For letter B, this is R1, which is seen here. We have the R2, R1, which is seen here. And we have R1 and small r for this. And another possible combination is R2, R, which is represented as the big D, small c, and big E, and small d, small c, small e genotype. So the answer is letter A for number 27. For number 28, which of the following will react with anti-F? So the choices are small r, big R1, big R1, big R2, big R2, big R1, big R2. So anti-F specifically react with the antigen F, which is present in the vast majority of D negative individuals. Although this antigen is said to be one of the unusual phenotypes and included in the rare alleles of the Rh system, this antigen F, if produced with anti-F, this anti-F is very reactive antibody that is capable of causing hemolytic disease of the newborn and transfusion reaction. So, for number 28, the answer is letter A. Letter A. Other unusual phenotypes and rare alleles in the Rh system are listed in this table. Please take note of the following. For number 29, which of the following mothers should receive RHIG, or we call as your Rh immune globulin? Choices are letter A, a negative mother with a O-negative baby, no prenatal care, anti-D is present in the mother. For letter B, AB negative mother with B positive baby with anti-D in mother. Letter C, O negative mother with A positive baby, no anti-D in the mother. And letter D, an A positive mother, A positive baby, and no anti-D in mother. Rh immune globulin, this is a human plasma-derived product consisting of IgG antibodies against D antigen. So this is used to prevent immunization to the D antigen among D negative individuals. This RHIG, this type of prophylaxis is very important in preventing anti-D formation, especially among females of childbearing potential. This is most important because anti-D can cause severe and later on potentially fatal hemolytic disease of the fetus and newborn. So for this question, what we need is an D negative mother. So this can be this, and this. And a baby or a fetus that is said to be D positive. D positive, D positive. The question is, when are you going to administer the RHIG? If the mother has already formed anti-D, meaning to say, meron na siyang previous exposure sa D antigen, therefore, nag-produce na siya ng antibodies against it, then this RHIG will no longer provide protection against the D antigen. So this is only indicated among D negative mothers with no anti-D in their plasma. So the answer for number 29 is letter C. Other criteria for administering RHIG besides from a mother being D negative, a mother with no detectable anti-D, the infant must be D positive, and also the direct anti-human globulin test of the cord blood must be negative. How does hemolytic disease of the fetus and newborn develop? So, sometimes a baby's Rh positive red blood cells enter the Rh negative mother's bloodstream. So this will allow the introduction of the D antigen towards the D negative mother. So the mother will then produce antibodies against the baby's red blood cells. Usually these antibodies do not affect the first newborn or the first baby that is in this first pregnancy, but future or subsequent pregnancies will be greatly affected. If a second baby is Rh positive, the mother's antibody will try to destroy the baby's red blood cells, putting the baby at risk for hemolytic disease of the fetus and the newborn. So how does the ROGAM works? So this ROGAM is said to be a prophylaxis, preventing this Rh negative expectant mother from making antibodies during her pregnancy. As long as the mother is under or receiving ROGAM appropriately during pregnancy, this would protect her and also the baby from the hemolytic disease of the newborn. For number 30, a group O Rh negative mother with no detectable anti-D and bearing an Rh positive infant, what course of action should be taken? So the choices are the following. Letter A, perform a Rosette test. B, perform a Clay-Hauer-Betke test. C, issue 1 full dose of RHIG. Or letter D, none of this. So to determine whether there is a fetal maternal hemorrhage, immediately, approximately an hour after the delivery, maternal sample must be tested for FMH or fetal maternal hemorrhage. This should be done regardless of the presence of detectable passive anti-D in the maternal serum. And for us to screen the presence of the FMH, we can use the Rosette test. This test is used to detect fetal D red cells in the maternal Rh negative blood. If the Rosette test is positive, a follow-up testing is done to quantitate the fetal maternal hemorrhage. So, for quantitative test for fetal-maternal hemorrhage, we can use the Clay-Hauer-Betke acid elution test or flow cytometry. So, for the Rosette test, we do incubation of the maternal red cell with the IgG anti-D at 37 degrees centigrade. This is followed by the removal of unbound anti-D, the addition of indicator red cells, and later on, we should observe, in case of presence of FMH, we could observe the agglutination or forming of rosettes microscopically. So, a positive test for Rosette test would be indicated with 3 or more rosettes in 10 fields or 7 or more in 5 fields. So this is designated as a positive result and suggesting that there is a significant fetal maternal hemorrhage of more than 30 ml. Therefore, it would require more doses of RHIG. So this is an example of the microscopic analysis after the method of Rosette test. What we can observe in the image A is a negative Rosette test result. Although this is a negative Rosette test result, the standard procedure would be the mother or the patient tested for this, even though she is negative, kailangan po, meron po tayong bibigay pa rin na isang dose or 1 dose of RHIG. So we have to give a 1 dose of RHIG to the Rosette negative mother. For letter B, this is represented a field that would meet the criteria for a positive Rosette test. So here, the number of Rosette present should be counted, and a minimum of 3 for 3 or more in 10 fields or 7 or more in 5 field would indicate a positive result. Number 31. A fetal screen yielded a negative result on a mother who is O negative and infant who is O positive. What course of action should be taken? The choices are letter A, perform a Clay-Hauer-Bethke test. B, issue 1 full dose of RHIG. C, perform a DAT on the infant. Or letter D, perform an antibody screen on the mother. So for this, if the fetal screen test or the Rosette test is negative, it is indicated the fetal maternal blood is negligible in a possible RHIG candidate or dosage. So what we can do here as a standard practice is we need to issue 1 dose of RHIG to the mother. So number 31, the answer is letter B. Answer po, letter B. For number 32, a Clay-Hauer-Bethke acid elution stain is reported to have a 1.3% on an Rh negative mother postpartum. What is the total volume of fetal maternal hemorrhage? So, recall lang po ha, the Clay-Hauer-Bethke test, this is an elution test. This is performed to quantitate the number of fetal cells present in the maternal circulation. This is done after the screening test or the Rosette test. Once the size of the fetal-maternal hemorrhage is determined, the appropriate RHIG dose can be calculated and administered to prevent the mother from making an anti-D. So, the test principle is the red blood cells with fetal hemoglobin are less susceptible to acid elution than the cells containing adult hemoglobin. So, for us to determine or to compute for the amount or volume of fetal maternal hemorrhage, we can use this formula. Number of fetal cells multiplied by the maternal blood volume divided by the number of maternal cell or we can simply determine using a simpler way to calculate the dose is to multiply this fetal cell percentage using an approximate factor of maternal blood volume of 50. So you can get both the volume of fetal maternal hemorrhage. So for this question, we have 1.3%. Since there's no indicated maternal blood volume or number of maternal cell present, we can use directly the simpler formula, which you multiply the 1.3 by 50. And it will give you the value of 1.3% multiplied by 50 is 65. Number 32, the answer is 65. So using this value, we determine that the total volume of fetal maternal hemorrhage is 65 ml. If this is a whole blood, if we're talking about whole blood, 65 ml divided by 30, it would give you a value of 2.17. If you want to determine the number of vials to be used in this Rh negative mother, using this computed value, we can assert that the mother requires a total of 3 dosage of RHIG. Why? Because here using the computed value 2.117, you have to round down the nearest number on the right after the decimal point. If it is below 5, you have to round it down plus 1 dose. If the value after the decimal number is more than 5, you have to round up the computed value plus 1 dose. So in this case, this is 2.17. We have to round it down as 2. Adding 1 dose, the answer is 3. 3 dosage. So in this picture, picture shows the results of a Clay-Hauer-Bethke test. So letter A illustrate a negative quantitative test for fetal maternal blood or hemorrhage. For letter B, this is a positive test for Clay-Hauer-Bethke test. The blue arrow in the bottom of this image point to the fetal cells. These are the fetal cells. While those red arrows, they are pointing on the maternal cells, which appear to be ghost cells. Okay? Number 33. A Clay-Hauer acid elution stain is reported to be 1.3% on an Rh-negative mother postpartum. How many vials of a standard 300 microgram dose of RHIG should be administered within 72 hours to the mother with this amount of bleeding? So, using the value in item number 32, so 1.3%, we multiplied it by the 50, giving you a amount of fetal maternal hemorrhage volume of 65. This 65 should be divided by 30. For whole blood, we use 30. For whole blood, we use a denominator of 30. So 65 divided by 30, you will get 2.17. 2.17, you have to round down. So the value will be 2, adding 1 dose. So the answer for number 33 is 3 vials. 3 vials. 3 vials of RHIG. For number 34, a feto-maternal hemorrhage of 35 ml of fetal Rh-positive packed red blood cells has been detected in an Rh-negative woman. How many vials of Rh immune globulin should be given? So we have here a value of 35 ml of FMH, which is said to be the packed red blood cells present or detected in the Rh-negative woman. So, how are we going to compute for the dose of RHIG if this is the amount of fetal maternal hemorrhage in the mother? So, we are talking about here the packed red blood cells. Kanina, ginamit natin is the 30 ml value. So, in one dosage of RHIG, that is actually equivalent of 300 microgram. This 300 microgram is proportional to the amount of the whole blood or the packed red blood cell. For the whole blood, 300 microgram is used per 30 ml whole blood. 300 microgram of RHIG is used per 15 ml of packed red blood cells. So, in this item, we don't use 30 ml, instead, we use 15. So, 35 ml divided by 15 ml, we get 2.3. We get 2.3. So, tanong, is this round up or round down? Again, tingin sa ating decimal number. Sa kanan, we have 3. This indicates that we have to round it down. So, we have 2.3. So, round down. That is 2 dose plus 1 dose. So how many vials or dosage of RHIG should be introduced to the mother? We have 3 doses. So the answer in number 34 is 3. The answer in number 34 is 3. 3 doses of RHIG. So we have I have prepared some exercise. Marami lang questions about the computation of the ROGAM kasi baka kailangan natin ng practice. So, a KB acid dilution test identifies 40 fetal cells in 2,000 maternal red cells. How many fold dosage of RH, sorry for this is dosage. How many full dosage of RHIG is indicated? So, kanina, sinulat natin yung formula. So, sulat na lang natin. Number of fetal cells multiplied by the amount of, or the maternal blood volume divided by the number of maternal cells. So using this formula, we can get the volume of the feto-maternal hemorrhage. So using the given, we have 40 fetal cells multiplied by the maternal blood volume. If wala pong given, we use the estimate maternal blood volume, which is 5,000. Again estimate po ito. All over the number of maternal cells present which is 2,000. So in this computation, we can get a 100 ml of feto-maternal blood. So in this case, this is your whole blood. Feto-maternal whole blood. So how many vials do we need for this? We need 100 divided by 30. We have 3.33. Again, round down. So 3 vials plus 1 dosage, or 3 plus 1. So the computed value should be, or the answer for this is 4 vials. Next exercise. The results of a Clay-Hauer-Bethke stain indicate a feto-maternal hemorrhage of 48 ml of whole blood. How many vials of RH immunoglobulin would be required? So again, meron tayong whole blood. So again, the value of 1 dose is 300 microgram of RHIG per 30 ml of FMH. So for us to identify, we just have to divide 48 by 30. So 48 divided by 30, whole blood, the answer is 1.6. This is round up. So rounding up plus 1 dose. So the number of vials needed should be 3 vials. 3 vials. 3 vials. So the result of a Clay-Hauer-Bethke stain for a postpartum blood revealed 0.7% fetal cells. What is the estimated volume of the FMH expressed as whole blood? So in this case, again, di ba, sabi natin kanina, you just multiply it with 50 ml. So we get for 4.7%, multiply it by 50, we get 35 ml of whole blood feto-maternal blood. So the answer here is 35 ml. 35 ml. So number 35, a mother is group A Rh positive, father is group O negative. Their child suffered from hemolytic disease. Which of the following antibodies is caused by this HDN? So, hemolytic disease of the newborn is commonly attributed among antibodies classified as IgGs, since these immunoglobulins are known to cross the placenta, among of which commonly encountered IgGs causing HDN are the Rh antibodies. So, these are IgGs. So, in the choices, we have anti-A. Anti-A is IgM. Therefore, it is not known to cross the placenta. We have anti-D. And we have small anti-D. But this is not possible because anti-D na maliit is not existing at all. Remember, the letter D indicates the absence of the D antigen, but not necessarily the absence of this D antigen will equate to an anti-D. Hindi po yun, ha? Mali po yun. So, letter D, we have anti-C na maliit. It is possible. So, we have left two possible choices. We have anti-D and anti-maliit na C. So, sa kanilang dalawa po, sino ang mas possible? It is letter D. Given that the mother is Rh positive, therefore, it has already the D antigen. The D antigen. So, kung ang bata ay mag-type as Rh positive containing D antigen, it will not pose a significant reaction with the mother's immune system. However, some Rh antigens, such as the small c antigen, if present in the fetus or from the baby's red blood cell, it can also cause HDN. So, most possible antibodies causing HDN in this case is anti-C. Letter D, anti-C. Number 36. If a D positive person makes an anti-D, this person is probably letter A, partial D, B, D negative, C, weak D as a position effect, or letter D, weak D due to transmissible gene. In this scenario, it looks like a weak D phenotype, presenting a weak D phenotype. This is indicated as this symbol. So this phenotype is a weakened form of the D antigen that in routine D typing or Rh typing, it will react with anti-D, but not with others. Weak D red cells have the D antigen but have fewer D antigens per cell than in normal Rh positive cells. So, in this kind of phenotype, we have different mechanism that are attributed in having a weak D phenotype. First is the genetic cause, which affected by a weaker expression of the CDE haplotype. We have the possession effect, which occurs when the C antigen is inherited to the D antigen. For number 3, we have the partial D mechanism. So in this mechanism, it occurs when a part of the D antigen is partially inherited. So in this case, this is commonly seen among partial D mechanism, weak D phenomenon. So it would type as D positive or RH positive, D positive person, making an anti-D antibodies. Remember also that partial D is, we term this as mosaic. We term this as mosaic. So for number 36, this is a presentation of a partial D or a mosaic mechanism for weak D phenomenon. So number 36, that is letter A. Number 36, letter A, partial D. For number 37, which genotype usually shows the strongest reaction with anti-D? A strong reaction with anti-D is often attributed in a rare Rh system phenotype, which is the deletion phenotype. This rare phenotype has been identified that do not react with the following antisera: anti-big C, anti-big E, anti-C, and anti-E. These individuals lack the genetic material or the functionality of it that has been silenced or changed. Many examples of the deletion phenotypes have an unusual strong D antigen expression. So strong D antigen expression. And this is frequently referred to the elevated D or exalted D, giving it the ability to strongly react with anti-D, antisera. So the deletion phenotype is presented or represented as D minus minus, D minus minus, indicating the absence of the following antigens: the big C, the big E, small c, and small e. For Rh null, it is written as like this. So, wala siyang D, wala siyang C, wala siyang E, wala rin siyang small c, wala rin siyang small e. These individuals are said to have Rh null syndrome and may demonstrate a mild compensated hemolytic anemia, reticulocytosis, stomatocytosis, slightly to moderately low hemoglobin in hematocrit with increased hemoglobin F, decreased serum haptoglobin, and may have an elevated bilirubin levels. For Rh mode phenotype, it shows the weakened expression of all Rh antigens. Just a weakened expression of all Rh antigens. Unlike itong si deletion ng phenotype, may missing. And Rh null, wala sila lahat. So in this case, number 37, the correct answer is letter C. Letter C. For number 38, the inheritance of the Sese and the Lewis gene produces which of the following phenotype? So we have the Lewis blood group system. So the Lewis blood group system, one of the most unique type of blood group system. This contains antigen, produce antigens, your LEA, LEB, which are located on soluble glycosphingolipids found in the secretions and plasma. And these are secondarily adsorbed, passively adsorbed by the red blood cells from the surrounding plasma. So these Lewis antigens are quite unique, unlike the other blood group system antigens, because these antigens are not intrinsically associated or created within the red blood cell membrane. So they are rather passively adsorbed rather than produced on the red blood cell membrane. So the key player genes are the following: the Lewis genes, the LE gene, H gene, and then the secretor gene, SE gene. So the Lewis inheritance, if this LE gene is inherited, the LEA antigen are found in the secretions of non-secretors, and this will be later on adsorbed into the red blood cells. Individuals inheriting only LE gene would have a phenotype of LEA positive, B negative. If, on the other hand, the SE gene is inherited in addition to the LE gene, the Lewis transferase converts the available H soluble structure to a LEB antigen, into LEB antigen. Therefore, this antigen would be adsorbed into the red blood cells. Individuals inheriting both LE gene and SE gene would have a phenotype of LEA negative and B positive. So for this question, the individual only inherits the Lewis gene. So only Lewis gene. So this would be the phenotype LEA positive, B negative. Number 38, letter A. Number 39, if a person has a genetic makeup of big H, small h, heterozygous A, Lewis, and small se, what substance would be present in his secretion? So here, para lang din siya nung number 38, no? So, what was inherited is the LE gene only. LE gene only. So, what would be the expected substance or antigen to be present in the secretion? And that is your LEA substance, your LEA antigen. So, number 39, letter B. Number 40, inheritance of big SE, small se, and the Lewis gene produces which of the following phenotype? So, kanina, diniscuss natin, once the LE gene is inherited, at the same time, the SE gene is inherited, both of them are inherited, what will happen to the phenotype of the individual, Lewis phenotype of the individual? It would produce, or it would lead to the production of the LEB, giving the phenotype of LEA negative, B positive. So number 40, letter C. Letter C. Okay, number 41. A patient has the Lewis phenotype LEA negative, B negative. An antibody panel reveals the presence of anti-LEA. Another patient with a phenotype of LEA negative, B positive has a positive antibody screen. However, a panel reveals no conclusive antibody. Should an anti-LEA be considered as a possibility for the patient with the LEA negative, B positive phenotype? In this case, some instances, those individuals secreting LEB, so individuals who have inherited the LE gene as well as the SE gene, they have still, or they can still secrete a minimum or small amounts of the LEA antigen. So, in this case, anti-LEA is not likely the antibody because LEB individuals may secrete some LEA. So the answer is letter C. Number 42. Given the following typing results, what is the donor's racial ethnicity? So we have here LEA negative, B negative, Duffy A negative, B negative, JSA positive, B positive. So, very important po, no, na medyo kabisado po natin yung mga prevalence per blood group system. Very important po na familiar tayo yung ABO, RH, Lewis, Duffy, and Kell. So, ayan po. baka po helpful sa inyo. Ito po galing kay Harmony. So, here, we have LEA negative, B negative. This is predominantly observed among black population. Duffy A negative, B negative. This is very rare among whites, and this is actually commonly seen among African Americans. For KEL system phenotype, particularly JSA positive, B positive, rarely seen among whites, and more commonly seen among blacks. So for here, given that this is Duffy A negative, B negative, this is more attributed among African American population. So for number 42, letter A is the correct answer. Number 43, the phenotype Duffy A negative, B negative is very prominent among blacks, which is nearly 100% among African blacks have a phenotype of Duffy A negative, B negative. What special trait accompanies those individuals who are Duffy A negative, B negative? So, in parasitology, we often discuss this and mention this. So, this phenotype is attributed in the resistance to malaria. Okay. An antibody shows strong reaction in all test phases. All screen and panel cells are positive. The serum is then tested with the cord cell and the reaction is found to be negative. What antibody is suspected? The following are the choices. So in this scenario, this is commonly observed in times when an anti-I is present. Anti-I, the big I, are naturally occurring antibodies. They are cold reacting IgM antibodies. So their characteristic is they fail to react with the cord red blood cells. They are associated with cold agglutinin disease. Therefore, this is associated with the infection caused by the Mycoplasma pneumoniae. And unlike other choices, this is not associated with hemolytic disease of the newborn. So other antibodies, we have the anti-I, rare cold-reacting antibodies, which is seen in infectious mononucleosis infection. So this may cause hemolytic anemias, unlike anti-I. So the testing to identify anti-I is done at 4 degrees centigrade using group O red blood cells or cord red blood cells. In the presence of cord red blood cells, what you can observe is the negative reaction with anti-I. So number 44, the answer is letter A, anti-big I, anti-I. Number 45, a patient is suspected of having paroxysmal cold hemoglobinuria or PCH. Which pattern of reactivity is characteristic of the Donath-Landsteiner antibody? Which causes this condition? The choices are the following. So, letter A, antibody attaches to the red blood cells at 4 degrees centigrade and cause hemolysis at 37 degrees centigrade. B, the antibody attaches to the red blood cells at 37 degrees centigrade, causing agglutination at the IAT phase. Letter C, the antibody attaches to the red blood cells at 22 degrees centigrade, causing hemolysis at 37 degrees centigrade. The antibody attaches, or letter D, the antibody attaches to the red blood cells and cause agglutination at the IAT phase. So, number 45, this is a characteristic of the, what would be the characteristic of the auto anti-P or the Donath-Landsteiner antibody. So, we should know that this Donath-Landsteiner antibody, this is called reacting antibody, which is associated with PCH or the paroxysmal cold hemoglobinuria. So, the mechanism of action of this antibody at cold temperatures, the antibody attaches to the red blood cells. It would attach with the red blood cells at cold. However, after the reaction of this antibody with the red blood cell at cold, when exposed to a high temperature of 37 degrees centigrade, it would cause hemolysis. So for number 45, this is correctly described for option letter A. Letter A. The antibody would attach to the RBCs at 4 degrees centigrade and will cause hemolysis at 37 degrees centigrade. Number 46. So, if during a Donat-Landsteiner test, there is hemolysis in both the test and the control tube, at the conclusion of the test, which of the following possible conclusion is most applicable? A, the test is positive. B, the test is negative. C, the test is invalid. Or letter D, the test is false negative. So, Donat-Landsteiner test is used as a diagnostic assay for paroxysmal cold hemoglobinuria. It is based on the principle of the mechanism of the autoantibody seen in paroxysmal cold hemoglobinuria. So, what is done during this test? So, there is a tube. There are two tubes. One is for the patient, and one is for the control. The test cell, the patient tube, is incubated at 4 degrees centigrade, whereas a control tube is incubated at 37 degrees centigrade. So after this initial incubation, the tube or the patient tube is then placed in a 37 degrees centigrade incubator. And then another incubation will be performed. So this would be from a 4 degrees centigrade. This will be incubated now at 37 degrees centigrade. So after centrifugation, these two tubes will then be centrifuged and will be examined for the presence of the hemolysis. If the hemolysis in the test is observed and there is no hemolysis in the control tube as seen in this picture, this would mean that the patient sample is positive for paroxysmal cold hemoglobinuria, or it contains or it has the presence of the auto-anti-P antibody. So, if there are no hemolysis found in both tubes, it is said to be a negative test result. Once both hemolysis are observed in both test tubes, the test should be considered as invalid. So in this case, number 46, both tests are observed with the presence of hemolysis. So therefore, in this case scenario, it should be considered as an invalid test or invalid assay. So number 46, letter C. Number 46, letter C. Number 47, which of the following antigens deteriorates on storage? Which of the following antigens deteriorates on storage? So, among the following choices, the P1 antigen is said to be labile and it deteriorates rapidly on storage. So, if we are using an older red blood cells for typing or used as controls for typing for some reagents, or we are using older RBCs used to detect anti-P1 in serum, what we can expect is a false negative reaction. We may expect false negative reaction. So number 47, it is letter D, P1 antigen. 48, a technologist is having great difficulty resolving an antibody mixture. One of the antibodies is the anti-LEA. This antibody is not clinically significant in this situation, but it needs to be removed to reveal the possible presence of underlying antibody of clinical significance. What can be done? So in this case, what we can do is to in this case, sometimes in the laboratory we encounter certain substances when mixed with the red cell antibody, they cause inhibition of its activity. So what we can do is to use the following reagents for us to neutralize the affecting substances. So if you want to remove the action of the anti-LEA, what we can use as a neutralizer is the saliva. So number 48, letter B. So it depends on the acting substances. If this anti-P1, what we can use is hydatid cyst fluid, pigeon droppings, turtle dove's egg whites. And then for anti-Lewis, what we can use is, of course, we have saliva, plasma, or serum. Anti-Chido or anti-Rogers, we can use plasma or serum. Anti-SDA, we can use guinea pig urine or just simply urine. Anti-A, what we can use is a mother's milk. 48, letter B. 49. Inhibition testing can be used to confirm antibody specificity for which of the following antibodies? The answer for this is letter C, anti-LEA. Anti-LEA. So for number 49, letter C, anti-LEA. So what is the use of inhibition for the following, for this type of antibody? So generally, inhibition of blood group antibodies by soluble substances can aid in the identification of specific antibodies. The antibody activity of known specificity can be selectively removed by using the inhibition method, leaving behind other antibodies to be identified. So this inhibition method are useful for antibodies that are said to be or some antibodies that can be inhibited by some soluble substances such as sugars, proteins, peptides, and these antibodies may be included among ABH, Lewis, P1, Chido or Rogers, and some antibodies such as the anti-P1. So for number 49, we have Lewis antibody. So letter C is the correct answer. Number 50, how can an interfering anti-P1 antibody may be removed from a mixture of antibodies? So from our list kanina, diba, the anti-P1 can be neutralized using the hydatid cyst fluid, pwedeng pigeon droppings, and then turtle dove eggs. Turtle dove egg whites. So number 50, the answer is letter D.